Bismillah ar-Rahman ar-Rahim. My name is Rani Mahmoud, lecturer of Pediatrics. Our topic today is about the IMCI, the Integrated Management of Childhood Illness. IMCI is a part of the preventive pediatrics, as physicians routinely incorporate the strategy in the second part. We will talk today about three main problems: the diarrhea, the sore throat, and the ear problem. The first question is, does the child have diarrhea? What is the definition of the diarrhea? Diarrhea means a change in the increase in the frequency and fluidity of the stool. So increase the number of motions that the child passes, and also the consistency or the softness of the stool is increased. So in diarrhea, stools contain more water than normal and more frequent passaging of stool. Frequent passing of normal stool is not a diarrhea. And also we should ask the mother about the normal habit of her baby. What is his normal bowel habit? He is passing motion 5 times, 10 times per day, because the exclusively breastfed infant often have a stool which is not diarrhea, and they can pass motion with each breastfeeding. So if they breastfed for 8 times, they could pass motion 8 times per day, and which is not considered to be diarrhea. So it's very important to ask the mother about her normal bowel habits of her child. First, we should assess the diarrhea. We have three classifications for the diarrhea. The first classification upon the degree of dehydration, which is the most important one. Each child with diarrhea should be classified for dehydration and degree of dehydration, severe or moderate or no dehydration. The other classification depends on the length of the diarrhea or the duration of the diarrhea, more than 14 days or less than 14 days, and the third classification according to the presence of blood in the stool. So we have three important classifications. The first one is for dehydration, the second one for the length of diarrhea, and the third one the presence of blood in stool. For the assessment of the dehydration, we should look at the child general condition. Is the child lethargic or unconscious, restless or irritable, and looking for the signs of dehydration. Signs of dehydration include three items: sunken eye and ability to drink. We offer the child fluid and asking him to drink. Does he able to drink, or drinking poorly, or he is drinking eagerly or thirsty? And the third item is the skin pinch or the skin turgor. We pinch a fold of the skin of the abdomen and to see does it go back slowly or very slowly. This is for the assessment of the dehydration, and it will be discussed more in details later. The second classification is for the length of diarrhea. Diarrhea lasting 14 days or more is considered to be persistent diarrhea. And the third classification is there is blood in the stool. Because a child who has diarrhea with blood in the stool, mostly he will have dysentery, and it will affect also the line of management. So, returning for the dehydration, we will look at the child's general condition to assess he is normal child, lethargic child, or unconscious child. The normal child is usually calm, well, alert, and can be consoled easily. If the child is unconscious, cannot be awakened, and cannot respond to the tactile stimulation or verbal stimulation or painful stimulation, and we should assess his score according to the Glasgow Coma score. Lethargic child is not alert. It could be drowsy, staring blankly, not responding well, but it could respond to painful stimulation or to tactile stimulation. Also, we should see if the child is restless or irritable all the time or every time he is touched or handled. Also, included from to assess the degree of dehydration. For the signs of dehydration, we should look for three items. Number one, for sunken eye. What is the meaning by sunken eye? Sunken eyes are deep-seated eye. And it's very important also to ask the mother about if there is a change in the shape of his eye, because it could be one of the normal variant, could be his normal that his eye is looking like deep-seated, But usually the mother, if you ask her, she could tell you that there is a change in the shape of his eyes, or it could be her complaint. She feels that his eyes are deeply seated from the severity of dehydration. Number two, we offer the child fluid and then see he is able to drink or not able to drink. If the child is not able to drink, it could be like comatose or lethargic and he is not able to drink or to take the fluid in his mouth and swallow it. He could drinking poorly. It means the child is weak and drink very poor, or he may be able to swallow only the fluid if you put it in his mouth, like by a syringe or cup or something. I tend to that the child drink eagerly or thirsty. إن هو ملهوف على المية. He would like more water. If you give him a cup of water, he would like more another cup. If you take the cup of water from him, he will cry and asking for more water. So this is a sign also that he is drinking eagerly or that drinking thirsty. When the water is taken away, the child will be unhappy and he wants to drink more. The third item is the skin pinch or the skin trigger. So you locate an area over the child abdomen midway between the umbilicus and the side of the abdomen. Then you place the thumb and index finger on the abdomen and take a longitudinal fold of all the layers of the skin and the tissue, and then release this fold after 1 second. And it is better not to use your fingertips. You should use the pads of your finger, not your fingertips, because the tips could be painful. Then you will see when this skin fold return back to the normal. If it return back to the normal immediately, this is the normal. If it stay from 1 to 2 seconds, it's slowly. If it take more than 2 seconds, it's considered to be very slowly. If you look at this picture, you see this fold of the skin. When you take it and you release it from the severity of dehydration, because this patient looks severely dehydrated, so this fold of the skin, it returns back very slowly. It takes more than 2 seconds. So according to all these items, we can make like a classification for the degree of dehydration. And this is the most important thing in the IMCI, to know these tables and to know the classification, because it will affect later on your management plan. As we mentioned before, that all the children with diarrhea should be classified for dehydration. Even if they don't have dehydration, we should say that there is no dehydration. If the child has had diarrhea for 14 days or more, we will classify as a persistent diarrhea. If he had blood in the stool, we will classify as dysentery. But the dehydration is the most important one. How we will classify dehydration? According to the following signs. If the patient has two from the following signs, from the following 4 items, he will consider it to have severe dehydration. If the patient is lethargic or unconscious, has sunken eye, not able to drink or drink poorly, skin pinch, goes back very slowly. Just 2 items from these 4 items, he will be considered to have severe dehydration. And what is meaning by severe dehydration? It means that this child will be managed according to Plan C. We have 3 plans for management of diarrhea: Plan A, Plan B, Plan C. This is a fluid management plan, because you have like deficit and the maintenance fluid you should give to this child. So this child which is severely dehydrated, he should receive his plan of fluid management according to Plan C. Plan C means that he needs from 70 to 100 milli per kg. If the child is 10 kilogram, he should receive from 700 to 1000 milli of fluid. He should receive as 20 milli per kg at shock therapy, very rapid on about 30 minutes, and then receive the rest of the fluid on 3 to 4 hours, and then reassessment of the degree of dehydration again to see if he is still severely dehydrated or he become some dehydration or no dehydration. Also, the child should be referred urgently to the hospital with frequent sips of oral rehydration solution if he can tolerate the oral fluid. The ORS is like a sachet. You would put one sachet on 100 ml of water and give him as like frequent sips by a spoon or by a syringe. If he is not able to drink or he is comatose, he will receive for sure the IV line and receive his fluid through his IV line. The second classification that if the child has two from the following also four items. If he is restless or irritable, sunken eyes, drink eagerly or thirsty, skin pinch, go back slowly. So if he has two from these four items, he will consider to have some dehydration. Some dehydration will be managed as a plan P. Plan P, he will need from 50 to 70 milli of fluid. If he is 10 kilogram, he should receive from 500 to 700. Also, he needs the child to be urgently referred to the hospital and receiving frequent steps from the oral rehydration solution on his way, and advise the mother that she can continue breastfeeding. Also, he could receive like zinc supplementation for 14 days, advise the mother when to return immediately, and follow up in 5 days if the patient is not improving. If you don't have enough signs to classify as severe dehydration, we will consider him as he has no dehydration. So we should give him fluid and food according to Plan A. Plan A is this patient should be treated at home. Plan A, it will be from 30 to 50 milligram per kg from fluid. So he could receive this fluid as an ORS, as breastfeeding, as water, as juices, whatever the child can prefer, because he will be able to drink and more likely he will be healthy and alert and normal child. Also, we can give zinc supplementation for 14 days and advise the mother when to return immediately and follow up in 5 days if not improving. So this table is very important for the classification of the degree of dehydration, because according to the degree, I will put my management plan. If you have two from the four items, either lethargic or unconscious, sunken eye, not able to drink or drink poorly, skin pinch, go back very slowly, he will be as severely dehydrated and he will be managed according to Plan C. If he has two from the following, restless or irritable, sunken eyes, drink eagerly, or thirsty, skin pinch, go back slowly, he will have some dehydration and he will be managed according to Plan B. Not enough signs to classify as some or severe dehydration, he will be managed according to Plan A. The second classification for the diarrhea depends on the length or the duration of the diarrhea. Persistent for more than 14 days, it's considered to be persistent diarrhea. If it is associated with dehydration, it will be considered to be severe persistent diarrhea. And so we will treat the dehydration before referral according to the previous guideline and then refers the patient to the hospital. So treat dehydration unless the child has another severe classification and referral to the hospital. If the patient doesn't have dehydration, he will be considered as a persistent diarrhea, and we will advise the mother on how to feeding the baby, giving the multivitamins and the minerals, advising the mother when to return back immediately, and follow up in 5 days. The third classification, if there is blood in stool or not. If there is blood in stool, we will consider that the patient has dysentery. And blood in the stool or dysentery is indicative of bacterial infection, because most of the diarrhea in children below 5 years mostly is due to viral cause or viral diarrhea, and we didn't need to have antibiotic, just we are needing to prevent dehydration or treatment of dehydration if it occurs. This is the most important item for me, is the treatment of dehydration and the fluid management plan. I don't need to have to give antibiotics, just the treatment of the dehydration and it will be subside. But if I have stool, blood in the stool, I should consider bacterial infection, mostly Shigella, and I should give oral antibiotic at least for 5 days. And advising the mother when to return immediately and follow up in 2 days. So these three tables are very important for the classification of diarrhea. Usually it's like a case and we can classify our patient and what will be our management plan. We have an exercise we can practice together. Sami is an 8-month-old infant. He has had watery diarrhea for 5 days and has blood in the stool. He has had cough for 3 days. On assessment, his weight is 8 kilograms and his temperature is 37.4. He is not lethargic, not irritable, not convulsing now, and didn't have convulsions. He has occasional vomiting. His respiratory rate is 32 breaths per minute. He has no chest and drawing, no stridor, and no wheezes. When you offer him fluid, he is eager to drink. His eyes are sunken and his skin pinch returns back slowly. So let's classify Sami illness. We will write his name, age, weight, temperature, initial visit, yes, follow-up visit, no. And what is the child problem? What are the child problem? Is diarrhea for 5 days and cough for 3 days. Usually the child problem is like the complaint in the history. You should take the mother's own words. You shouldn't say like he has dehydration or something, because this is your assessment later on. So our child here has diarrhea for 5 days and cough for 3 days. Does the child have any general danger sign? No, because these are the general danger sign: lethargic or unconscious, convulsing now, not able to drink or breastfeed, vomits everything, history of convulsions. So our child didn't have any of the general danger sign. Does the child have cough or difficulty of breathing? Yes. For how long? 3 days. Count the breath in 1 minute, 32 breaths per minute. Look for chest and drawing, stridor, wheezes. He didn't have chest and drawing or stridor or wheezes, so no pneumonia, cough or cold. Does the child have diarrhea? Yes. For how long? 5 days. Is there blood in the stool? Yes. Look at the child's general condition. Is the child lethargic or unconscious, restless or irritable? Look for sunken eyes. He has sunken eyes. Offer the child fluid. Is the child not able to drink or drink poorly? Drinking eagerly or thirsty? He is drinking thirsty. Pinch of the skin, does it go back slowly or very slowly? It go back slowly. So what is the classification of our child? Child mostly have some dehydration, because he have 2 from the 4, or yes, has sunken eyes and the skin pinch, go back slowly, and drink eagerly or thirsty. But our child has another classification because he has blood in the stool, so he has also dysentery. So this is our 2 classification, and our management plan will depend on this classification as regarding his fluid management, and also he will need antibiotic because he had dysentery and suspecting to be due to bacterial infection. And you should come like this case, it could be one problem, it could be more than one problem in the case, and usually you do your classification and your management plan according to the classification you put. The second problem in our lecture today is the sore throat or pharyngitis. And what is important for us is to classify, is the streptococcal pharyngitis or streptococcal sore throat or non-streptococcal sore throat. Correct treatment of sore throat or pharyngitis is a preventive intervention of rheumatic fever and rheumatic heart disease, which may follow group A streptococcal sore throat. So this is the most important for us. We would like to pick up the population who are considered to have streptococcal pharyngitis or sore throat to decrease or prevent the risk of rheumatic fever and rheumatic heart disease later on after group A streptococcal sore throat. Sore throat or pharyngitis is mostly viral in the under 5 children. Only 15 to 20% of sore throat episodes in the under 5 are caused by group A hemolytic streptococcus. Despite this, sore throat is mostly treated with antibiotic. There is abuse of the antibiotic, but we only need antibiotics if you are suspecting that this is a streptococcal sore throat, because as we mentioned, most of the other causes of the pharyngitis or sore throat are considered to be viral, so there is no need to give antibiotics for the patients. So how to classify for or check for throat problem? We have to ask about 2 items and examine 3 items. We should ask the mother if the child has fever and if the child has sore throat. Mostly if this child is more than 2 years, he can explain that he has difficulty in swallowing, pain in his throat, but if he is less than 2 years, it's mostly difficult to assess if he has sore throat or no. By the examination, you should look for enlarged tender lymph node in the front of the neck for the cervical lymph node. If you have like red congested throat, white or yellow exudate on throat and tonsils. So at first we will ask the mother if the child has sore throat. If the child is less than the age of 2 years, it's unlikely that one can know whether he has sore throat or not because it's difficult to express. We should examine the baby for any tenderness, enlargement or tenderness in the cervical lymph node, hotness, redness, swelling, tenderness in the cervical lymph node. And we should examine the child's throat. But because the examination of the throat is usually unpleasant for most of the children, so it must be delayed and be the last step in the examination. It's also important for the position of the child correctly, as you see in the picture, and make sure that you have a tongue depressor and source of light, either torch or use the light of your phone. To see. If you see this picture, you have like enlarged, congested, red tonsils. If you look for the other pictures, you will see like yellow streaks here and white exudate on the enlarged tonsils. So according to this finding, as regarding the history that we take from the mother, if the child has fever or sore throat, and regarding your examination, we will classify our case either streptococcal sore throat or non-streptococcal sore throat or no throat problem. If the patient has fever plus 2 of the following items or sore throat plus 2 of the following items, he will consider to have a streptococcal sore throat. So fever plus red congested throat or white or yellow exudate on the throat or tonsil or enlarged tender lymph node in the front of the neck, he considered to have a streptococcal sore throat. If he has sore throat plus 2 of the following also, red or congested throat, white or yellow exudate on throat or on tonsil, enlarged tender lymph node on the front of the neck, he will classify it as a streptococcal sore throat. And the most important item here that I will give this patient is the benzazine penicillin, because to prevent the risk of rheumatic fever and rheumatic heart disease following group A streptococcal infection. We should soothing the throat with safe remedy, give paracetamol for pain, advising the mother when to return immediately and follow up in 5 days if the child is not improving. The other classification, if the child has sore throat or not enough signs to classify as streptococcal, you'll consider him that he had no streptococcal sore throat. It could be like viral sore throat or viral pharyngitis. So I will not give here antibiotics. This is the difference. I will just give soothing the throat with safe remedy, paracetamol for the pain, advise the mother when to return back immediately and follow up in 5 days. If there is no throat signs or symptoms, so I will consider that he has no throat problem and we should continue assessment of the child. He could have another problem. The third problem and the last one is the ear problems. And also the most important item for the ear problem is to classify if the patient has mastocytitis or acute ear infection, chronic ear infection, or no ear infection. Also, we do our classification according to 2 items asked to the mother and 2 items in the examination. To assess the ear, the mother if her child has severe or agonizing ear pain. Usually if the child is more than 2 years, he can talk and he can express that he has severe ear pain and agonizing ear pain. For the younger children less than 2 years, Usually he can pulling his ears downward, persistently pulling in his ears, or severe crying and severe irritability because its pain is very painful. The other question, if there is ear discharge, and if there is ear discharge, you should ask about the duration of this discharge, how long it take. The other item for the examination, you should look at pus draining from the ear and feel if there is tender swelling behind the ear. For the agonizing ear pain and the ear discharge, there is inflammation of the middle ear cavity behind the eardrum. The fluid accumulates and causing pain through increasing pressure in the middle ear cavity, leading to rupture of the eardrum, perforation, and the pus, then leading to discharging the pus from the ear. The ear for the mastocytitis and the parotid swelling. Usually the parotid gland encircles the ear lobule from the front and below the ear and behind the ear. Usually the parotid swelling like make a swelling in the side of the cheek and the front of the ear and the back, but in case of mastocytitis it's only tender swelling behind the ear. So to classify our ear problems, we have to make also this table. If you just have tender swelling behind the ear, it's considered to have mastocytitis. And if you're suspecting mastocytitis, you should give the first dose of the appropriate antibiotic, the first dose of paracetamol for the pain, and that treats the child to prevent hypoglycemia or low blood sugar, and urgent referral to the hospital. Number two, if you have like pus seen draining from the ear and discharge for less than 14 days or agonizing ear pain, you will consider that this is acute ear infection. And in case of acute ear infection, you can start giving antibiotic like the amoxicillin for 10 days, give paracetamol for the pain, dry the ear by wicking, advising the mother when to return immediately, and follow up in 5 days. If the pus is seen draining or the discharge for more than 14 days, you should dry the ear by wicking, and it's considered to be chronic ear infection, so you should refer our patient to ENT specialist. If you don't have ear pain or pus draining from the ear, so you don't have ear infection, and you have advised the mother to go to ENT specialist for further assessment and evaluation. So on the level of the general practitioner and the pediatrician, you have just to pick up the patient who have mastocytitis and acute ear infection or acute otitis media. Mastocytitis is a serious condition. You should suspect if you have just a tender swelling behind the ear, and you should urgently refer this patient to the hospital. Pus draining from the ear and discharge for less than 14 days or agonizing ear pain, it's considered to acute ear infection, and you should give antibiotics for 10 days, paracetamol for the pain, and drying the ear and advising the mother when to return back. If you have persistent discharge more than 14 days, consider it to be chronic ear infection and refer to specialist. If you don't have ear pain or pus, no ear infection, and you should also refer to specialist. So to summarize, we took today 3 items or 3 problems. The diarrhea with its classification, and the diarrhea has 3 important classification according to the degree of dehydration, according to the length or duration of diarrhea, and according to the presence of blood or mucus in the stool. The most important that every child with diarrhea should have at least a classification for dehydration, either severe or some or no dehydration, plus the other 2 classifications if they are present. According to the items you will find, you will classify this patient, and also his plan of management will depend on your classification, either plan A or plan B or plan C of fluid management according to the severity of dehydration. The other problem is the sore throat or pharyngitis, and the most important to classify is the streptococcal pharyngitis or streptococcal sore throat or non-streptococcal, because in case of streptococcal pharyngitis, you have to give the patient benzazine penicillin to prevent the risk of rheumatic fever and rheumatic heart disease. The third problem that we talk about is ear problems. Also, you have to classify if this patient has mastocytitis to urgent refer this patient to the hospital, acute ear infection to start antibiotic treatment, chronic ear infection to refer this patient to ENT specialist, or no ear problem or no ear infection. Thank you.